I hope you've enjoyed the first part and the little bit of discussion we've just had. This is our second session that's also pre-recorded. So again, same format really. We're just gonna, we've got some slides, but really it's going to be us discussing the content, and then there'll be time afterwards for us to discuss that with you guys. So absolutely, please write in the chat box, put your thoughts in there if you want to share, and we'll pick them up at the end. Great. Okay.
So we've had a bit of a time to reflect and discuss. So we're hoping that the chat we've had has brought up some interesting ideas. And we're going to move on now to just talk about some things that may well have come up during the conversation. We wanted to just give you a bit more of a structure around some ideas around leadership. Because clearly we know from what happened in the Elaine Bromley story and in other investigations into when things haven't gone very well, and indeed when things have gone well, that the leadership style and the leadership approach is a really interesting one to think about. I found this particular piece of work by Margaret Wheatley really interesting because it talked about a style of leadership which has moved away from being a hero leader to being a host leader. There are many leadership styles. Many of you will have studied this, and there are very different approaches. I think my light bulb moment when I was studying leadership styles was to understand that there isn't one that you have to follow. There are many, and actually a good leader will be able to adapt their style to the situation they're in and to the style of the person that they're working with, and what personality traits, what negotiation styles are coming over. And that's a really interesting kind of process to kind of move into when you can become a more mature leader, really. And this work by Margaret Wheatley really touches on some of that, because I think we've grown in an area where this hero leader is seen to be the person that is the way to go. And this is described in very straightforward terms. Clearly, it's a bit black and white. Nothing is quite as black and white as this description. But a hero leader is somebody who we expect the leader to have all the answers. They know everything. They are the experts, and they will have all the answers. And therefore, they will tell people what to do. And importantly, point 2 is people will do what they're told. They will have clear instructions, and they'll follow those instructions. And it's a high risk areas that we work in. The notion of this hero leader is that those high risk areas require a high level of control. And this is all about taking control, being in charge, being the expert, and telling people what to do. And there may well be, and I'm sure you can probably think of some situations where this does work within healthcare. And there may be that little pots of that hero leadership style is what needs to step in and be done. However, if that is the approach that always happens, there are risks associated with that. And Margaret Wheatley would argue that actually we should shift towards this hosting leadership style, which is really much more, as it says, about allowing conditions, providing the ability for people you work with to do that work together. It's all about delegating, allowing people, supporting people, getting them to do the stuff, and it isn't all about the leader. And a key part of a host leader is that they absolutely insist on learning from experiences. And those experiences, that learning can be about positive experiences or negative experiences. They are honest. They don't cover over things. It's not all positivity and lovey, but actually there's an insistence on learning, reflecting, and moving forward and making change from the experiences. These type of leaders need to offer unequivocal support. Their teams need to understand that their leader will have their back regardless, no matter what. And that actually there will be a period of time for that host leader will have to defend their work and their team from other leaders who actually want to take back control. And I think we've probably seen a bit of that in crisis times that we've been facing in the last 12 months in healthcare. They feedback regularly to the team members, and that's a really important part of this. And this is all about being honest as well. And they make achievements visible. Now, that's a really interesting one. This is about those outcomes being very, very visible, and that this is about positive visibility of stuff that's gone on, but also when things haven't gone so well, that is open and transparent and discussed, and we have this candor about situations. And she talks quite interestingly about the value. They value the spirit of the team, but that with honesty. This is not sort of false rah-rah, hello everybody, we're all wonderful, lovey. This is with honesty and with integrity. And I think the interesting question we should ask ourselves is which out of these two do we think is a more difficult leadership style to work with? What takes more time and input? And who can we think of? Who in ourselves, when are we one or the other, or somewhere in the middle? What situations would one work better than another? And actually, why maybe sometimes do we naturally move towards one way of doing this or another way. This is a very broad sort of black and white, two ends of the spectrum, and clearly there's a big space in between where people work with a bit of each, really.
Yeah, no, I definitely agree with that. And I think for me, it's kind of like touching on what you said about making things really visible and having that understanding with the team, and you're going on that journey to take the team with you, and do you know, where do you get the buy-in from the team? And it's about that transparency of okay, this is where the vision is, or these are what the problems, what are your thoughts on that, and linking that back to actually remembering that everyone's really diverse and offers something different, and how does that all feed into each other. But yeah, like you say, there's times for both, and how does that work in practice, and how does that work for what you need in that moment. And I guess one thing someone always reminds me is that, you know, anyone can be a leader. You can be in a formal leadership role, as it were, but anyone can be a leader. And you know, your band 2s, your band 3s, your band 4s, or 6, 7, 8, whatever, like anyone can show leadership qualities, and that's really important to value and remember. In that it's not always the people that doing brackets, but you can't see that as like the in charge people, isn't it? It's who else is showing these leadership qualities in your team.
Definitely worth thinking about, and I certainly influenced me when I started to think about this and what my journey had been into leadership, and you know, why I acted in certain ways in certain situations, and how I observed what others were doing, really.
And I guess it's that trust as well, isn't it? And that's the maybe the, I don't know, that differential between the both of them is that actually, you know, can you just insist that the people in your team trust you, or do you have to build that with them? And that's really, really important as well. And what are the benefits then of actually building that with your team?
And we feel like you can work with a team that you can build and recruit and design your team around different personalities and all that fancy stuff. Often a team is just a bunch of people who turn up, who've answered a bleep and turn up and have to find a way to work as a team and understand this stuff in the moment, very kind of on the hoof. And leadership then it often may be turned into the hero thing, but I would suggest there are elements of host that need to come into that, even in a critical situation. It's an interesting one to consider, really. I think another really interesting resource for you to think about, if nobody has read this book, it sort of talks about leadership in a very kind of critical and extreme circumstance. And John is a journalist, and he was joined a group that were climbing Everest. And it's a fascinating read. I think there's a film about it. I think it might be called Everest, indeed. And basically things went very wrong during a, you know, let's call it a routine climb of Everest. Who would have thought that climbing Everest would turn into a routine thing? But it's turned into, if you've got enough money, you can go up Everest, regardless of whether you are suitable to do such a thing or fit or it's the right thing to do. And the decision making, there were some very strong personalities making decisions about what would happen on the particular day when they were to make the ascent to the summit. And there was clear knowledge and skill around why they should or shouldn't do certain things in this very risky situation. And yet, even despite that, those experienced, strong-minded leaders were influenced to make decisions which ultimately ended up in disaster and tragedy and the loss of life. And that's not to blame those individuals. The point is that there was when you read it, it's really fascinating. So if you want to figure out more about leading in extreme circumstances and understand the influence of others, it's quite an interesting read. I would recommend it. So let's start to think about a couple of other kind of little theories, really, I guess, and information that you may come across yourself when you start to look at human factors, understanding of how we work and how indeed decision making is influenced. Leaders are often the ones making decisions, but also so are other people in all sorts of situations. And I think it's really interesting to think that you can consider that there will be some bias to all the decisions we make. And it's worth just noting that up front. We are human beings, we're influenced by stuff going on around us. But it has been noted that these biases often will fall into these four sort of groups, really. There's this idea that it's just easier to keep things the way they are. The easier decision is just to stick with stability and kind of just do the same thing, really. It takes a lot more courage, time and effort to make a decision to do something different. There's also this idea that the social norm or social harmony bias really influences us to make a decision, actually, unbeknownst to ourselves. These are unconscious biases that we recognise that actually we basically quite like to do what our peers are doing. Just quite want to follow the crowd in a way. Or we just want to be recognised by our peers as not standing out and doing something too crazy. That's in a very simple term. Clearly, there's a whole sort of spectrum around that. The present bias, I think, is really interesting. It's about caring about now, and that we often will put a stronger weight to the payoffs that are closer to the present time. And I think I would accuse myself of this often, especially in terms of working in a very acute medicine. We're talking about the here and now and what's happening straight away, and that is much more satisfying to see the response immediately to what we do rather than a longer term outcome for the decision that we made. Is harder for us to sort of get the satisfaction from or to see the impact from. So that's an interesting one to think about. And this confirmation bias, you will have seen examples of this where what we tend to do is seek out information that confirms the existing opinions and subconsciously overlook or ignore information that goes against those beliefs. Everybody will do this, and that's why you need the value of a good team of people and people who will work very differently from others, who will off the wall come up with something completely different, or will challenge and speak up and go, but you've ignored this information here, this is important. And we need emotional maturity to understand that we might react like this in situations, and when we're highly stressed, we're likely to react even more so in these situations. This other kind of idea of decision fatigue is an interesting one. I think this slide's a little fuzzy, but again, this piece of work was pulled together and has been published from the parole board decision making. I think it was in Israel. It's quite a few years ago now. And what this idea is that over time, making a repeated difficult decision over time will mean that actually this shows over a long period of time the parole board's decisions were impacted. So from first thing in the morning until their first break of the day, if you were a prisoner up for the parole board, you were more likely to get your parole agreed, and therefore you'd be released from prison earlier in the session you were than the later in the session. And the degradation in that sort of decision making, if that's what you would call it, was really marked. It went right down to 0 on some of the occasions. So, and the reason for that, we think, is because people, the releasing somebody from prison is a more difficult decision to make than keeping somebody in prison. The harder, riskier thing to do is to let them out. And therefore, earlier in the session, when you haven't made repeated decisions, when you haven't been in this situation for a long period of time, you're much more likely to have the resilience and the ability and the courage to make what could be the right decision, but is the riskier decision. Whereas later in the session, be it just before lunch, just before break, clearly there are mitigating factors. Maybe they were hungry, maybe they were tired, there was a number of things. But this can be seen, this was a large-scale study, and it was also seen in another study that was done with GPs prescribing antibiotics. And actually later in the sessions, they were much more likely to give antibiotics to somebody who came in with a respiratory infection, even when the guidance was reasonably clear that that particular situation for that particular patient, when the notes were reviewed retrospectively, that antibiotics wouldn't have been indicated. But actually, a person sat in front of you going, doctor, I've got a chest infection, give me antibiotics. The harder thing to do is to say, no, you don't need them, I'm not going to give them you. In a way, in very simple terms, if you like, the easier thing to do is to give them the antibiotics. And the later in the session these decisions went on, the more likely it was that the decision to give antibiotics would be done. And that's really interesting, isn't it? To think about how we are influenced by that. And another way that our decisions are kind of molded, if you like, is, again, if you look this stuff up, there's some really interesting work out there around called choice architecture or nudge theory, which is this whole idea that there's a way that our behavior is altered predictably, but without removing choice. This is not forcing somebody to do something. This is about creating a situation where they're much more likely to do the thing that we want them to do, or the design or the process or the situation is required. Many of you will have seen this example. This is, I believe, Amsterdam Airport, and there are some urinals where they were having an ongoing problem where there was spillage from the urinals, urine on the floor, and it had an impact on many, many things: timing, resource, cleaning up. infections, all sorts of reasons why this was an issue for the organisation, and it wasn't the look that they wanted for their shiny airport. And they tried all sorts of ways to try and enforce a change of behaviour. But in the end, they engraved a little fly, which you might just be able to see, onto the urinals. They didn't tell anybody, they didn't force anybody, they didn't put any notes that them say, aim at the fly. But by putting the fly in there, then they ended up with improved aim in the urinals and much less splashing and much less kind of consequences of that for the organisation. And that's just one sort of example. There are many out there, and I would encourage you all to have a little look and think about this nudge theory, because I think we can see it in our workplaces. It definitely comes into ergonomics in how places are designed, how we're encouraged to walk in certain ways around airports. Look at the floor when you're in an airport. It will guide you without forcing you, but it will guide you to certain places. It will guide you to do certain things. I think we've seen quite a lot of that with COVID restrictions, with COVID guidance. How are they trying to get us to do the right thing without taking away the choice? And that's the important bit here. We are, in a way, subconsciously being manipulated, if you want to think of it that way, or being moved or shoved towards certain things. There was examples certainly within our ITU, one of our clinicians was describing how they had like a red, amber, green light system, which they then displayed in teams around outside the rooms, showing how compliant each sort of bay, if you like, was with ventilator bundles. And although people were reporting compliance with ventilator bundles, the data that we can now get from all our electronic systems was showing there wasn't full compliance, and they couldn't quite understand why, despite telling everybody. And without making a big fuss about it, they just sort of put up this almost, you get a little reward of a green if you're doing well with your ventilator bundles, and without forcing anybody or taking away choice, actually there were improvements. It showed across the board improvements in compliance with the bundle. And that was just one example of thinking, how do we influence people to do what we want them to do without forcing them? Because in healthcare, we're very innovative. We like to get around a problem. And if you try and force me to do a certain thing, you can think about, you can only connect a certain tube to a certain connector, and now they've taken away the ability to connect the wrong tube to the wrong connector, because that's a risk and we don't want that to happen. We don't want to give drugs by the wrong route to somebody, so therefore they changed the design of it. But you and I all know that give us a little while, we'll probably find enough different connectors to make the thing fit the thing if we're determined to do it. And that's the brilliant thing about innovation, and that's the bad thing about innovation. Whereas if you can find a way to nudge people towards the right stuff, then that's an interesting way to go about it.
I find that really interesting, because I know there was, I think it's in Germany, there was a big park, and actually they decided that in this green space, actually what they would do after they've designed all this park, flowers, everything, we're not going to put the paths in. We're going to wait a year, and then we're going to put the paths in afterwards, because we're going to see where people have walked, and then that's where we're going to put the paths in. And I find that really interesting, because you think, well, the human brain will always find a way to do something in a certain way. So actually, do we have to get a bit clever about that and think about how we work with that environment, and the fact that, again, we're working with humans and we have human behavior and we're not robots. So
very true. Okay, so we thought it would be interesting right now to just spend the last few minutes of this session thinking about what the publications, what the journals are now telling us, and what the experts are telling us when they've applied a human factors and ergonomic analysis to the last 12 months of COVID-19. And there is some work coming out now from China and from Italy, who were amongst the first sort of large healthcare organisations facing the biggest challenge around this. And I'm sure we'll all recognise many of these things that are sort of themes that emerge from this analysis of human factors, if you like, within the healthcare situations people found themselves in. This idea that there was a need to adapt rapidly, I'm sure you will all recognise that, that there was just constant change within the first 3 months of this. So we were reflecting how we didn't know what we were doing tomorrow, but actually we didn't know what we were doing this afternoon for part of the time. So there was constant change, and we needed to adapt to that rapidly. So that was in and of itself a risky situation and a challenging situation. There's been a massive amount of engagement with the public, and the only way that some of this health crisis has been managed to the extent that it has, if you like, is because of engagement with the public and their understanding of how things need to work differently. We always try to engage with the public, but this has gone off the scale with that, really. Working across boundaries, they are both professional, departmental, everything, every possible thing. Everybody's worked very, very differently. And clearly there's this element of real concern now around fatigue and burnout amongst our individual staff, amongst teams, but also amongst an organisation which has just worked at its limits for a long time. And this has not been a crisis that is over in a couple of weeks. This is a long-term crisis, really. So that notion of fatigue and burnout has been recognised across the piece. This notion that there's been an absence of trust amongst care teams, and I don't think they necessarily mean that that's individually, I don't trust you as an individual person in a really sort of accusing way, but this is about, I'm used to working in a team of people in ITU, let's say, you're all highly trained and all specialists in ITU, and now you've given me a military guy who's never worked in ITU before and somebody who retired 5 years ago, and I've never met them before and I don't know what background they have, and they were recruited yesterday and they've started today and they've had some very quick training to be here. And that whole notion of I'm not quite sure what they can do, what can I do, what's my role, what's their role, has been massive. And that's been going on across the world, really. The ongoing lack of time for patients and self-care has also been reported across the piece. And I think it's interesting that we talk about not just the patient, but also ourselves and how are we able to be resilient. And this notion of psychological safety, really, this whole idea, I think, you know, day one of all of this crisis, we were focusing maybe on physical safety. Did we have PPE? Were we all going to get sick? What might that look like? And alongside that, absolutely almost an hour later was, crikey, what does this mean? You know, how do I feel working very, very differently? And we know that providing care in uncertain situations has been shown to reduce performance. And I think the last 12 months has been uncertain situations around them. Now, the people who have been sort of studying this and applying this human factors, ergonomics, engineering approach have applied this version of the SEEPS model, which we talked about in the first section, and have looked at these various sections within this. So applying this to what were the work system barriers and what were the facilitators, what happened during COVID-19 and how can we break that down. And the aim of breaking it down is probably to find a way to begin to tackle some of these things. And without understanding what these things are, it's very hard to just say, well, we need to change it. This allows us to do a deep dive into what's going on. And you can see some of the examples that we came up with here and some of the solutions that were brought along as well to try and help this really, really challenging and unusual situation, really. I think from our perspective, we got involved in just-in-time training. We got involved in simulation so that we were testing systems. We were trying to get people and systems up to task quickly, but actually also exploring where the challenges and the risks would be. And even just simply thinking about where is the PPE and where do I get changed and where do I don and off. Those things changed over time, and they changed in order to be more effective and efficient and safer and work better. And that's this is a process that goes round and round and round. It gets influenced by the outcomes, gets influenced by what's going on, gets influenced by the outcomes. Anything?
No, it's just been a very complex situation. I think that whole part about that psychological safety, and again back to the slide we showed in the previous section about your buckets, and I think everyone's buckets were exceptionally full, and you know it's that part again that you know I remember the conversations very early of people asking us when we were training PPE, and you know, is my father going to get sick? Am I going to be safe at work? Am I this? And it's like all those real worries that we've had to deal with in a really challenging situation that has never been experienced really before by, imagine, any of us.
So what can be done about this? Well, you'll have all experienced various different processes that have been put in place, various different interventions that you, yourselves, your teams, your colleagues, your workmates have put into place to try and deal with what we recognise are these kind of factors that have influenced and made life tricky. The measures that get discussed in some of the most recent sort of publications on this I love this idea that simple measures can make a big difference. And I think we've probably seen that. And you often talk about that with the buckets. If our buckets are really full, so what can I do? Just really saying to somebody, oh, my buckets are full, or I'm just really, really struggling today. can I just at least share that with you? And just the fact that somebody goes, okay, I know, thank you for letting me know. I've got your back. Tell me what you need. Sometimes that just takes a little bit of the brass out of the bucket, and you can get on with your day and be a bit safer. But really simple measures can make a massive difference. Working differently has really challenged us, but actually it's a way of intervening and making what is a complex situation different, but work more effectively. And we can see that in many different ways. And learning lessons is really important. So very early on, people were trying to make sure, have we learned from this? What can we share? We were hearing stories from Italy, but also lessons from Italy and interesting notions from Italy amongst the ICU networks, and all sorts of people were saying, we've tried this, tried doing this worked well for us, that didn't work. And we've all worked together much more in this situation than we perhaps have done in the past. And one of the things that came out from the Italy experience early on was that this whole culture that they decided was really important to say is that help seeking is okay. It's okay to seek help for your patient, for the work you're doing, and for yourself. And that's a subtle change potentially to how maybe we've worked in the past. And there are some real lists of things that you'll have seen happen. This idea of huddles, that was really helped all those new people that are coming in that work differently, don't know what's going on. Other people don't know what they can do, but actually a quick huddle. Who are you? This is what we're going to do. That's your role. Any questions? That type of stuff can really break down those barriers and really start to give people clarity. Checklists, we'll have seen checklists a lot, and actually the more uncertain the situation, the more we need to go, let's just pause and go through this list. Let's follow an algorithm. Let's have a process that anybody can pick up and read and follow and do. The notion of debriefs is massively important, and clearly we're big supporters of the idea of debriefing within education, but debriefing within clinical environment is massively important. And finding time, even if it's a very short, quick, hot debrief and then followed by longer abilities. And sometimes those debriefs are really informal. And we have breakout rooms for our staff. I know there was little areas where they could just go for a quiet room, and that would either just be completely on your own, or maybe somebody might join you and you might just let it out for a bit. And this pushed forward the whole world around health and wellbeing. And it's seen now as a really positive thing, and certainly our organisation has really received lots of resource from amazing work by Captain Tom, and that really came through to the health and wellbeing sort of interventions that we could see. I think specialist teams is a really interesting one. I think the example I can think of is a proning team in ICU. Didn't have such a thing before. We all got involved in proning, and then for a period of time at least, there was a proning team, and that was their role, to be specialists in that role. Didn't have to think about anything else complex skill, but actually let's let a specialist team do it. And that's a kind of different way of working. It's a task allocation way of working, which is a different way to how we work in healthcare now. The notion of recognition and thanks has really gone high up on the list within our organisations and within each other. And recognising this halt, and we've got some work going on here around it. It's hungry. I can't remember. I wrote it down as well. Tired is one of them. Tired is one of them. Lonely, that's what it is. Hungry, angry, lonely, tired. So the idea being that you can speak up when you're feeling vulnerable yourself, or you're feeling any one of those things, and it's like it's time for a break, regardless of everything else that's going on. But don't look after me for 5 minutes now. I'm not going to be able to do anything to help anybody else. And clearly Laura and I are real fans and supporters of the idea that simulation can help. But we've used simulation over this time to really just try and tease out some of the problems, or to train people up quickly, but actually make it experiential and give them some confidence. But also to test out systems. We opened a vaccination hub in our building here, which hadn't happened before. And, we had very little warning. It all happened very quickly, but we still found time to do a real live few hours simulation to test out the systems. If we hadn't done that, we would have followed a system which was been pulled in from somewhere else, but actually didn't really work for us here. And so because we were able to test it out, we were able to make changes on the ground, test it again, pick up that lesson, take that to our nearby other hospital where there was another vaccination hub. And that enabled some improvements. It then moved on as things happened. Clearly things moved on, and they still learned from. But at least it was done, first of all, in the day before the clinic opened, really. We've talked about this, but really this idea of psychological safety for ourselves, because it can impact on so many reasons, let alone our own clinical performance. And this idea that it's everybody can voice a concern, and that's a really important idea, this culture of safety. And how do we act within that for ourselves?
I know there was a study that I was reading a little while ago about sort of by Harvard University, and they looked at actually, this there's leaders again in teams where staff actually the staff that the leaders that were perceived as the better leaders, as it were, actually there were sort of more errors or more concerns that were raised on those people's shifts, and they really sort of dug deep to look at why that was. Why is it that these people were deemed as the best leaders, but they seem to have the most errors or the most issues? And yet it was all about, the members of that team feeling comfortable to raise those concerns with those people. So I always find that really interesting.
Good. That is good. And that touches on one of the things that's come out of this whole sort of notion of safety too, as well, but also on this rewarding and recognising success. Many of you will have seen or been part of the excellent work coming out of Birmingham around learning from excellence. And the notion of this is that they want to make sure that they learn from what's working well in our organisations and provide positive feedback to staff. So they've created a number of things, not least of which a system called Greytext, which is Datex, but for good things. And there will be other examples that you will have seen. There's lots of examples now of, rewarding people, recognising staff's efforts, recognising individuals, recognising teams. These things don't come without their risks, and I think it's important to understand there are two sides to all of these type of interventions, and not least of which is actually, what do the public and media say and think if we want to concentrate on the good stuff that the NHS does? And I think Laura touched on this earlier. For the last year, there's been nothing but positive media for the NHS. And everybody thinks that NHS are heroes. Everybody in the public and the media are still within that space where they are saying good things about what we all do. You will all know that more than 12 months ago, that's not the case. Usually the things that get the headlines are where things have gone wrong, where there's a complaint, where there's an incident, where there is something untoward that's happened that is a negative connotation. And even when good things happen in a negative situation, the things that get reported are the bad stuff. We were talking earlier about an example where there was a fire in our oncology hospital here. And what was reported the next morning on the news from our local reporters was interviewing the chief exec, sort of saying, we hear that there was adult patients put on the adolescent ward. Why did you do that? We heard that there was bad stuff happening. What went on? As opposed to, that was 1% of the situation. Actually, all those patients were safe, they were careful, they were inside and they were on a ward. But actually, they didn't mention the fact that the entire hospital got evacuated very quickly. Nobody was injured. No, there was no loss of life. And the next morning, by lunchtime the next day, the place was kind of up and running pretty much full pelt. So the fact that they couldn't report the positives because the media, and by media we mean the whole range of media, and we have to include social media in that and the power of it. And it's really worth thinking about if your organisation or you as a team want to really focus on learning from the positives. Often our resources, sadly, are still heavily put into root cause analysis of when things go wrong, as opposed to can we understand all the other places where it's gone right, and what can we learn to help those areas which are struggling to achieve that all the time. How is that learning shared rather than the other way around? So that's the end of our sort of pre-recorded piece, and we will regroup for a few more minutes of chat and respond to some of your questions and some of your comments and some examples. Thank you very much, everybody.
Thank you.